to just give you a little introduction and background into what my study was, there's a gap, and I think all of you as nurses understand this, there's a gap in transition for new nurse graduates from education and practice. And a lot of this is greatly related to the role that experience plays in their readiness. So with this gap, we know that it's getting greater, and it's widening, and there's a lot of reasons why, but most of the reasons are because there's been changes in healthcare. So one is that we all know acuity level is higher than it's ever been in the hospital in the past. The patients are sicker, and as far as taking students into the clinical area, patient safety is a big issue, and that limits the experiences that we can give to our students. So that's another concern. There was an article that was written by McNellis in 2014, and it was a qualitative study, and she went in, she looked at what we do in the clinical area with our students, and the biggest impact is that we really miss a lot of opportunities with them. When I go into the clinical area, I have myself and 8 students. Some people have 10 students. So when I'm with one, then the other 7 are out there, and they're missing opportunities that I can help them with learning. So that's a concern. In addition, about 50% of the baby boomers or the experienced nurses will be retiring, and about 42%, it's projected, 42% of the new hires in acute care will be new graduates. So if we're losing the experienced nurses and we're replacing them with new graduates, we need to do something to prepare them for practice. On the practice side, there was a survey done by the nurse executives, and they looked at new nurse competencies, and my study really targeted the areas that were in need of most improvement for new graduates. And those were recognizing a deteriorating patient, so new graduates had difficulty with that. Prioritizing, as well as anticipating risk, that was a concern. Delegation and tracking multiple responsibilities. So how can we improve that? New graduates we know are vulnerable, as well as their patients are vulnerable. So there are a lot of initiatives that are underway and to optimize their performance, and one way, which is kind of the target of my study, was the use of simulation. So what is simulation? Simulation is when you take a student and you put them into, and all of you, if you've been through nursing school, know this, we put them into a laboratory environment, and because of the improvements in technology, we now have patients that are simulated patients but take on a lot of actions of almost a real patient. So it has been really helpful. It's a safe environment for students to learn in. It also allows them to make mistakes and then learn through reflective learning how to improve the care. So most of the work in simulation has been done putting a student with a single patient or a simulated patient. And a lot of my work has been done in looking at multiple patient simulation and how can we have that student take care of more than one patient to assimilate practice and take care of more than one patient at a time and help to bridge that gap. Here it is. So the purpose of the project was to explore student behaviors related to performance outcomes during a multiple patient simulation. And the 2 questions that I asked were they able, and remember back to the nurse executive survey, were they able to use surveillance to identify a patient who was having complications, and could they just identify the patient first, and then could the senior level nursing student take action in a timely fashion in order to manage that complication correctly. So quick review of the literature. They found that simulation definitely improves student learning. It improves self-confidence. There's a lot of satisfaction students find in learning within the simulation laboratory, and that critical thinking is improved. But again, a lot of that literature has been done with a student taking care of one patient. And we know that in a lot of cases, students even coming out of school, 80% of those students have only had one or two patients by the time they graduate in the hospital. So lacking from the literature is looking, that was my gap, was looking at the use of multiple patient simulation and how effective is that as a teaching learning strategy. So this is my theoretical framework, and I looked kind of broadly at what experience plays in gaining knowledge. And I looked first at a social science side with David Kolb, brought it down to nursing with Patricia Benner, looking at the role of experience as somebody moves from novice to expert, and then all the way down to simulation with Pamela Jeffries' simulation framework. And that's based on the constructivist theory, and that says that we construct knowledge through experience. The methodology that I use, I actually guided my methodology using the NLN Jeffries simulation framework. And I did that because of the positive correlation between all of the simulation design and student outcomes, and I was actually looking at student outcomes. So this is my methodology, just taking a few of those concepts from her framework. And I had 30 students that I recruited. There were 12 in the primary nurse role, and there were 18 in the support role. So the 12 that were in the primary nurse role were the target of my data collection, and they were the last semester students getting ready to graduate. They didn't have any experience in healthcare prior to coming to school. And then the support role participants were also last semester students, and they were just the personnel you'd see in a hospital as well as family members. So that kind of rounded out the scene, so it looked as if it was a real hospital and we had real players. The simulation design characteristics, I used the NLN scenarios, which are evidence-based as well as peer-reviewed, and I used 3 patients, and one of those patients was a complex patient that needed assistance. So they needed to identify that one patient, but they still had 2 more they needed to manage. And the setting itself was a med-surg setting, so it had all the nuances of med-surg, charts, medications, etc. And then the student learning outcomes, I videotaped, or I didn't, but a videographer videotaped the primary nurses providing care in the sim, multiple patient sim. And I had an independent rater view those videotapes and evaluate their performance using the Seattle University simulation evaluation tool. And this tool is valid, reliable. It is based on the AACN Essentials of Baccalaureate Education. And it is used for simulation evaluation. Its purpose is to look at performance outcomes. So what I found, or this is just an example of the tool. There were 5 criteria. This isn't the whole thing, and I know this is busy, but what I want to show you is, if you can look here, these are the behaviors that the students were to perform in assessment, and then there's a Likert scale that goes across, and the independent rater looked at the videotapes and then looked at the behaviors and then rated the student across that Likert scale. And there were 5 criteria that we looked at. So the results, and this is overall, but this is each of the 5 criteria at the bottom. We looked at assessment, critical thinking, communication, direct care, and professionalism. And you can see it's pretty inconsistent in their ability to answer those questions, to the 2 questions that I had. Were they able to identify the patient, and then were they able to manage it correctly? So where it says meets, generally there were some things in there that they weren't doing, even though they met according to the rubric, they met that particular expectation. But embedded in each one of these areas were behaviors that you saw on the tool before. So to drill down a little bit further and answer the questions, can senior level nursing students utilize surveillance and identify the patient who has subtle cues of complication? When you look at their ability to recognize changes, what they did was they focused on physical tests. So they applied oxygen. This was a patient who had a DVT and had a pain in their calf. You can see they definitely evaluated the leg, but and they did put oxygen on because they had very subtle shortness of breath, as if the patient was having a pulmonary embolism. So they put oxygen on, but they didn't gather enough information to really understand what was happening. So they never listened to breath sounds. Well, not never. Some of them did not listen to breath sounds. And anticipating risk, they didn't anticipate that this patient might need an IV access, so they never checked patency, thinking that perhaps they may need that in this emergency situation for medications. So question number 2, can senior level students take action in a timely fashion to manage the complication? When you look at prioritization, they were really inconsistent. They didn't all sit the patient up, which is kind of nursing 101. And I know they know to do this, but you put them in that environment of having to manage more than one patient, it's difficult for them to pull it all together. So inconsistent of sitting the patient up, and reassessment of the O2 level, O2 saturation, after they applied the oxygen to the patient. So when I say inconsistent, it doesn't mean that they all did it. They didn't all perform that. Delegation, they delegated, there was a PCT, but they delegated to the patient care technician, but there was a charge nurse, and they maybe a couple delegated to the charge nurse the care of the other 2 patients that they had, so that they could focus in on that deteriorating patient. So delegation was an area that still was consistent that they need to work on. Communication, they did a fairly good job with communicating with a provider, but they didn't always give all the information that they needed to give when they made the phone call. And this is a little more telling of a slide, tracking multiple responsibilities. Basic safety practices were missed, such as identifying the patient and washing their hands. So, you know, we know they know how to do this, but putting them in that environment, how can we help them to move and be able to manage all of these basic safety practices? However, you can see just the opposite. When you look at begins a heparin drip, 10 of them did start the drip, but they hadn't identified the patient. So, let's see, wrong way. Oops. So the limitations of the study, it certainly was a small study. I only looked at 12 primary nurses, and so that limits generalization. It was a convenience population, and they were all second-degree students, so the GPAs may have been, or were higher, and they also had education prior to coming back to school. So we really need to interpret these findings carefully. Implications for nursing. The National Council State Board of Nursing just came out with their findings of replacing clinical with simulation. And what they found was that we can now replace 50% of clinical time with simulation, and it will not affect NCLEX results. And it wasn't statistically significant when they looked at the improvement in critical thinking. However, that group that had 50% simulation did have a little bit better critical thinking skills coming out of school. Other implications, the use of multiple patient simulation if you design it well according to the framework, and if it's very thoughtful in how we put it across the curriculum, that it's a useful teaching learning strategy, and it can hopefully help fill that gap between education and practice. Certainly research is needed to replicate the study with in larger scale with multiple colleges and universities. Simulation is just really hard to research because you can only get small numbers out of one school because you need all of the players in your sim. And then research is needed on transference of knowledge gained from the sim lab out into practice, and does it have any effect on patient outcomes. And in conclusion, the study gathered valuable information to broaden the understanding of the relationship between education and practice, and the opportunity to enhance the performance outcomes of new graduates. It certainly highlighted the role that experience plays in educating nurses, and it supported my theoretical framework, and it provided evidence for the use of multiple patient simulation to move the student along in education to its successful transition into practice. Okay, so do you have any questions?
So with the multiple patient simulation, they actually had like several dummies and then one started having an issue?
Right.
Is that what happened? Okay.
So the NLN scenarios have core and complex levels. So there were 2 core patients, which were patients that were not acute. I mean, they were hospitalized, but they didn't have any complications.
Okay.
But they had things they had to do. And then the one that needed help was the complex case. So it was the person who had surgery, was not ambulating like they should, had a DVT, very subtle shortness of breath.
Okay.
And they had to be able to manage that.
And how long did the simulation experience last? Was it 20 minutes?
It was 20 minutes.
20 minutes.
Yeah, it was 20 minutes.
Cool.
Yeah. And then we did debrief. So it wasn't that I only did this.
Right.
For the study, that's as far as it went, as far as collecting my data. But we debriefed for 40 minutes and went through, we used debriefing for meaningful learning with this group. So,
I was curious about the debrief actually. How did they feel they did?
They felt that this is all anecdotal, of course, but they felt that it was very useful because they recognized that they didn't delegate when they should have, and all of those areas that the Nurse Executive Committee saw that were, those are actually ranked at the very bottom, being able to recognize deterioration and tracking multiple responsibilities. They were like, wow, Now, you got to remember, I did these students at the beginning of a semester, and they had, at different times, they had externships or internships, and so I did them all early so that they were all the same before, because they flip-flopped. But
I think they actually learned their delegation part in their leadership classes kind of near the end of their 4th semester. So maybe they got that.
Right. But the charge nurse was right. She was right there. It's interesting. Yeah.
So just a question about some of the findings. I think that this is what I saw. I thought it interesting that they didn't do well with the hand washing as an introduction, right? And
Right.
So with all of the safety issues in hospitals now, there's a huge push.
It is.
Very basic.
Right.
Introduce yourself, explain what you're doing, wash your hands.
Right. Right.
But they did well with some of the more complicated.
More complicated, and I think it's not that they don't know to do this. We know they know. It's just putting it all together to be able to, so that all that hand washing and introduction and identifying a patient is almost habit, and I don't think they've gotten there yet because, again, it's experience. It's getting out there and doing it.
And also, it seems like there's more time creating longer
Exactly, yeah. All the residencies. And simulations are in several hospitals. And I think that's really helpful. My argument a lot with simulation is that are we just mimicking what we do in clinical anyways by giving them 1 or 2 patients? Why aren't we then saying, oh, well, this isn't working, so maybe we need to have the nuances of a hospital if we have all of this technology now, and help them, to move in a safe environment and say, oh, you didn't wash your hands, so that they recognize it. Mm-hmm.
Sabrina, were the patients all high fidelity mannequins and then
No.
other participants?
They weren't. They were vital sims, so they weren't high fidelity, so there wasn't a control room, but the family members, and we put it all together so that the roles were well defined by the people who were the support roles, so they were well vetted before the simulation started. So it helped to make sure that they got the information they needed to make decisions.
Well,
Okay, good, thank you.
Right.